Hey people, how you doing? We're live. Welcome to the Sports Therapy Association podcast, episode 198. My name is Matt Phillips, creator of RunChatLive.com. And as always, this episode of the Sports Therapy Association podcast is being recorded live on a Tuesday. But it's not at 8 o'clock, is it? It's at 9 o'clock. And I'm sorry if that's thrown you off. But really, I couldn't have a better reason for this because the next three guests, basically, for the next 3 weeks are in Australia. So I'm getting them up at 6 o'clock in the morning instead of 5. So, hey, it's the least we could do, isn't it? So, yeah, it is at 9 o'clock. I hope you still managed to find your way here if you are joining us live. But as always, this will be uploaded as a podcast available on all normal apps, including Spotify. And the video recording will be on YouTube. So yes, this episode is part one of a 3-part tendon special, giving you, the dear listener, the opportunity to spend an hour in the company of 3 world-leading experts in tendinopathies. In part 1 tonight, coming up very shortly, entitled Tendon Treatment, What the Research Says, my guest is going to be Professor Peter Malliaras. And then next week on May the 21st, also at 9 o'clock BST, British Summertime, it's going to be Understanding Tendinopathies of the Hip and Pelvis with the one and only Dr. Alison Grimaldi. And then in part 3 on May the 28th at 9 o'clock BST in episode 200, we've reached the big 200. That's 200 weeks in a row, not bad, all because of COVID. So there you go. The topic's going to be managing tendon pain with special guest, Dr. Ebony Rio. So if you are listening to this podcast and you're interested in, well, you should put everything down to join us for the quality of those guests. All our guests are quality, but in particular, if tendinopathy is an area of interest to you and you have clients who are suffering from tendinopathy in its many forms, then you really should if you missed tonight, just put the next 2 weeks for free, okay? 9 o'clock BST. You can join us on the Sports Therapy Association YouTube channel and also on Facebook if you prefer. Right then, as I say, my guest tonight in part 1 is Professor Peter Malliaras. He's one of the most highly respected researchers and educators with regards to tendinopathy, co-author of over 100 peer-reviewed publications, and is 100, that's a bit old now. I'm sure it was 212 last time I looked, and is currently Associate Professor at Monash University Physiotherapy Department in Melbourne, Australia, hence our slightly later starting time. He's also creator of the internationally acclaimed Mastering Lower Limb Tendinopathy course, now in its 7th edition, which, as we'll chat later on, is available online as a lecture on demand, 16 hours of CPD, and occasionally in the UK. He's been here last time was November, and there are thoughts in the pipeline that may be coming over next year as well at some point. So without further ado, if you are joining us live in the lounge, then feel free to ask questions. This really is a great opportunity for you. Just jump in there. But yeah, sit back and enjoy part 1 of our tendon special with Professor Peter Malliaras. Professor Peter Malliaras, how are you?
Good, very good, Matt. How are you?
I'm good. Can I refer to you as Pete from now on? Because it's just a bit of a mouthful. No disrespect to the professor title, obviously, but it's just going to take me a long time.
I can call you Matt.
Yeah, you don't have to use my title. That's really, you can leave that behind. Mr. is so overdone these days, Mr. So yeah, great. Thanks again. I can't say so much. Thank you so much. I know you're an early starter and you enjoy it. You've probably been for a run already, but 6 o'clock. Thank you very much for making time to join us for this hour.
No problem at all. Happy to be here. Thanks for having me on.
Right, so just to say, people are joining us live, which is fantastic. I've given Pete permission just to cut me off completely if there's an interesting question in the chat. So do people ask questions, use this opportunity. It's a huge opportunity. The next hour is going to be for you. Cecily there saying, let's kick. Oh, she's already asked a question. I better hide that. I've got to do a bit of an introduction first, Cecily. I didn't mean questions now. That's better, Sarah. Just not jumping in with a question. That's a bit more British. Evening. Looking forward to this one. Thank you, Sarah. Geez, Cess, just calm down a little bit. Okay, we'll come to your question later on. Straight away. Oh, no, hold on. I think it's a joke. Okay, here we go. Let's kick off with a terrible joke. What do you call Kevin Bacon with no Achilles tendon? What do you call Kevin Bacon with no Achilles tendon? I feel like the level of the show is just dropping rapidly, but any ideas? I don't know. You can write the answer in there. Kevin Bacon with no Achilles tendon. Don't know. Come back to us on that one. That's a cliffhanger if ever I saw one. Right, looking forward to the answer there, Cecily. Thank you. Right, so Pete, you were our guest in episode 91 of the Sports Therapy Association podcast, which was just over 2 years ago. 2022. I know I said I'd call. Sorry, I've been really busy, but 2 years later, you're back on the show. So thanks for that. how's the last 2 years been? Been busy?
Yeah, it's been good. It's been good. Yeah, I've been so still working at Monash full time, still doing 1 day a week in the clinic. Yeah, so keep busy with that sort of stuff. Still seeing the usual sort of tendon patients in the clinic, doing lots of tendon research, supervising lots of students. So pretty much just all systems go last couple of years. How about yourself?
It's yeah. I mean, we're talking about research and evidence and stuff like that, and that's such a big theme now. And we're finally, I think, moving into quite a nice place, particularly bringing just different disciplines together. Even last time we spoke, there was probably still battling between physios and sports therapists and massage therapists at the bottom of the pile. It was all kind of like people trying to champion their own discipline. But now the true spirit of multidisciplinary care and patient-centered focus is kind of working, and we're all maybe needed in that circle of care. So it's, for me, speaking to people like yourself, there just seems to be a common theme coming through now, that the titles are kind of being taken off the wall and people are just talking about the patient, which is really cool. It's really exciting.
I agree. The way that I think about it is that there's a core group of enlightened people, and they're the ones that are sort of following the evidence and trying to keep up to date. And then there's people in all professions that don't bother. That's just a blunt put it.
That is a good way of putting it. But there's also now, I don't know, as far as we're seeing, without staying on the topic for too long, but there's kind of what I'm enjoying, and it's just my personal bias, is the evidence is accepting the fact that you don't just run your clinic according to what the research says. That wouldn't be evidence-based. You've got to take into account the patient's expectations and what the patient wants at that particular time. We've had a lot of talk about that, the whole idea of a 3-pillared stool and that sort of stuff, or a funnel approach, whatever you like. And because there is a little bit in England anyway, particularly on social media, a bit of a kind of a almost fascist-like, that's not supported by research, you mustn't do that. And it's like, well, mate, if you're just going to do what's supported by research, you can have a very quiet clinic, because not a lot of what we do is supported by research, or at least it's a bit grey. So, but hey, that's what we're going to talk about tonight with regards to tendinopathy. Massive topic. Okay, Cecily, Kevin Bacon without an Achilles is called footloose. Yeah, that's of course it is. Footloose. It's fantastic. Thank you. That's your one joke for tonight done, Cecily. That's the card gone. No more. Right. So how I thought would work today is I had a look at ResearchGate. It's going to be a little bit like This Is Your Life, I'm afraid, Pete. We're going to take a trip back time. And it also, because people interested, I'm hoping there's people who don't know about you, because if we're just talking about you to people who already know you, it's a little bit of an echo chamber. So just to stress the contribution you've played to research, particularly in the role, not just but tendinopathy. I found the first paper you did was, well, the first published one was 2004, which was with Jill Cook, whose name will appear quite a few times. And I'd quite be interested to hear about your relationship with Jill Cook and how that all started. But yeah, 212 publications. For people who can't see the screen, if you listen to the podcast, and I've just brought up ResearchGate for Peter Malliaras, 212 publications, 194,833 reads, 6,322 citations. This should make you feel very old. And then the only one I put on the screen, 2004, which was neovascularization and pain in abnormal patella tendons of active jumping athletes. So I thought, as a little intro, how did you get involved in that? And how did you get to do it with Jill Cook?
Right. So basically, that's going back to 2004. We probably started that research in 2001 when I started my PhD. And I just sort of was a fresh-faced young physio at that time who was 5 years out of basically training, and had done an honours during my undergrad, and thought, the next step that I wanted to do was a PhD. And it was more just serendipity, to be honest. I'd been working with sport, I'd been working with various I guess overuse tendon type problems, but hadn't really developed speciality in that areas yet. And then the opportunity came up at La Trobe Uni, where I did my undergrad, and Jill was there, and that was sort of how it all started. yeah, basically we then planned a PhD. We planned like 3 or 4 studies for the PhD. Did that. Finished that in 2006. And this was one of them. This was one of the studies. Yeah. This was actually not directly in my PhD because Jill's the lead author. It was one that we did with the PhD data, but it was related to the data collection that I did for my PhD. So for my PhD data collection, basically followed up a group of 100 plus volleyballers over a season. And we looked at them every month, and we did, imaging and measures and testing and strength, and we got a bunch of different questions answered from that data collection. And this one was really related to what's the relationship between pain and sort of other imaging measures like Doppler in the tendon. So back in those days, in the late 90s, early 2000s, there was very much a mechanical view of what tendon pain was and what tendinopathy was, and it was all about what's going on in the tendon. I don't think we ever talked about things like the biopsychosocial model or anything else in those days, and we would look at what could be the cause of problems from a very mechanical lens. And one of the ways that we looked at it was, are these vessels, these blood vessels inside the tendon, could they be contributing to the pain that we're seeing? And what we found in this study is that maybe they are related. And that's probably still true. There's some relationship between things like Doppler, but it's not the full story as we know. Now, it's certainly not a clear relationship between any pathological feature within a tendon and pain, even though some of them might be related in some studies and in some subgroups. In other subgroups, there's no relationship. So it's quite variable, and that's one of the challenges of looking at the literature. It's not always consistent. Often that's explained by study design or by the populations people are looking at. But that's sort of, yeah, you're right. That's sort of where it all started with that paper.
That's really interesting, to hear how things have changed. And it doesn't sound like 20 years ago. It's doing my brain in a bit, thinking 2004 was 20 years ago, but it is. So back then, you said like terms like biopsychosocial weren't even around, even though the theory was put out there relative to, I think, psychology as opposed to healthcare or something. But when you look back at how your brain was working then, do you kind of think, oh, what was I thinking? Or is this all ridiculous? Or do you kind of accept the fact that's what we had at that time and we were going with it? Because there's a lot out there. There's a lot of people, sadly, we see this on social media, people standing on soapboxes and saying, oh, you're just looking at the mechanics. You're not even considering the psychosocial factors. And it's all a little bit, but we were all doing something different 5, 10, 15, 20 years ago. And if you weren't doing something different, then you're lying, because you know. So how do you look back at yourself 20 years ago? Do you do it with, what was I thinking? Or do you, I was doing it the best as I could?
I personally don't worry too much about the past. I think we're all on a journey of learning and improving, and regardless of what you thought even yesterday, as long as you're improving and you're thinking, you're willing to change and willing to improve. That's the main thing for me. So I'm not. Oh, so I've got a visitor here.
That's fine. For people listening to the podcast, there's a dog on the screen. In case you hear, it's not actually Peter slobbering. It's a beautiful Labrador, I think.
Trying to lick my face off. I just think there's no shame in having. I guess it comes back to our education. We're all educated, and a lot of us still are educated in the biomedical model, and that's to be able to shake that off and move beyond that and practice in different ways is a positive, regardless of when you come to it. So I don't really think there's, and back in those days, you're right, it was it was sort of what everyone was doing and what everyone was talking about. It's sort of taken a while, probably longer in tendinopathy, but I think it sort of goes back to the conversation we had earlier. We're all getting to an evidence-informed view and perspective now of different conditions, not only just things like back pain, and that's a really reassuring thing. I think that's really good.
That's good. I mean, that's good to hear from you. And it was a bit of a leading question, but I just know that from a lot of our listeners do worry about the fact that they've, especially with sports therapy and sports massage therapy, because a lot of the courses out there still have got dodgy information. They're still being told some courses that, things like you're breaking down scar tissue, that you're increasing the risk of cancer or miscarriage, and all these sort of things. And some people are horrified and they get so worried about the fact they've been told something that's not quite true. They find it difficult to move on. And really, your learning process is just like you say, tweaking it a little bit, evolving and not looking back and going, oh, what was I thinking? How embarrassing. Especially with patients, I think a lot of therapists are scared to go to their patient and say, you know what we were doing for the last month or two, I've just read something interesting, we're going to tweak it a little bit, we're going to try and do something a bit different. I think, would you say that patients are going to be less scared about that than therapists are?
Yeah, absolutely. Patients love that. Patients appreciate that. They appreciate when you're honest, I think, and you say, look, these are the limitations of what I know, or this is what I think. Maybe you need to try something else. Or I think honesty is always I think appreciated by patients. They take that on. They really appreciate that. So, and I think it's the same with us and what we know. And not everyone knows everything, and we're all learning, I think. And that's the way that I always view it. And that's why I do research, because we are always learning. And I certainly don't know everything, nowhere near it when it comes to, my wife would say I don't know much about anything, and she's probably right. But also in tendons, I don't know everything, and that's good, because otherwise I'd be out of a job.
There you go. I mean, if Professor Peter Malliaras doesn't know anything about tendons, then you guys have got nothing to worry about. So that's great. No, it's just really healthy to hear. So I appreciate that. Let's change what's on the screen here. I'm just going to move through time a little bit and just hear your thoughts. If the particular paper might just stimulate some thought with regards to that paper, or it might be another one which comes to mind, but I've just brought a few up in chronological order. I'll read it out on the screen for people who are listening to the podcast. So this was, we've zoomed forwards at just a year now, 2005, factors associated with patella tendinopathy among a cohort of volleyball players. So patella tendinopathy, obviously a lot of our listeners who are allowed to work with injury will come across patella tendinopathy. So I'm just interested to hear about what you were looking at the time and how things have changed with regards to managing patella tendinopathy.
That you're really testing my memory now, Matt. That's great.
I told you. I'm sorry.
We basically, with that one, we were interested in. So it was a sort of long-term prospective study, and we were interested in following up, and we did a bunch of work on. We did this sort of cohort where we followed people up for 6 months, and it was all volleyball players. And we're interested in does their pain change, does their imaging change, if those two things were changing together, if they were related at all. We're interested in other factors. We measured a bunch of strength and hopping, jumping type variables. And we were interested in some of those variables as well. So sort of trying to understand what factors, impairments are present, and also trying to get at some of the risk factors as well. So that's sort of where that came from. I guess the biggest learnings from that we had sort of led to. It was sort of interesting in a way, because we sort of found that, and I guess we sort of appreciate this more now, but we we didn't see a progression of pathology. People can play volleyball at a very high level and still not experience, falling in a heap and getting much worse, and their tendon getting worse and those types of things, even though they've got a quite severe problem. So the things like that, I guess, were some of the learnings that came out of it. People are quite resilient, and even people playing volleyball, jumping multiple times a week with a painful patella tendon, some of them got better during the season. Some of them got worse, some of them stayed the same. And we weren't really able to relate that to loading very clearly. And it was probably other factors as well. So that was interesting. And again, it sort of challenges your mechanical view of load is everything when it comes to a tendon. And, we're sort of overloading people. We should be advising them not to do these activities because they're potentially, damaging. So that was part of it. The other part that came out of that was that sort of led to some of the studies that Jill went on to do for the Continuum model. So that cohort, so it was quite a good bit of data that we're able to collect with that and move on to sort of understanding some things. Jill went on to look at it in a lens, and obviously not just with that cohort, but with some other stuff, with a lens of how do tendons change over time. Because what we found with some of those prospective studies is that you do in the patella tendon at least, you get changes that are, sort of, I guess, very mild first, and then it goes to a more severe, what was termed degenerative change. So, and that came from that cohort of that PhD cohort. So we saw that in those volleyballers. Some of them were normal, healthy tendons, and then they went to this reactive, what was termed reactive, which was mild pathology. Then they went to more severe. So there were some interesting things that did emerge from that data collection.
So that's interesting. I'm glad you mentioned that, because that was kind of seen, the whole, even now the continuum of Jill Cook and Craig Purdom is kind of mentioned, the continuum of tendon pathology. Can you explain to listeners who aren't aware of it how that affected clinical practice, in terms of, if you do appreciate the 3 different stages, and how does that change how you're managing tendinopathy in patients or clients?
Yeah, so look, it did have quite a profound impact on clinical practice. So it was at the time quite a, there's been lots of different advances throughout the last 3-4 decades, with Hock and Alfredson initially, and then Jill Cook. And I think that sort of made people think more about, it did make people think more about, I guess the principles that I took out of it were things like changing in load, getting people to appreciate the effect of load, both positive and negative, on a tendon, thinking about different ways to manage people who are loaded, who have sort of come to get a real sort of severe response to load, which we see clinically, versus people who, are just not really changing that much, and load is not the factor. Maybe they've had it for a little bit more persistent. So they were the positives that came out of it. Probably the negatives that came out of it were a very biomedical lens, again, focused on tissue and focused on load. So again, we've moved beyond that a bit, and we know that even though the Continuum taught us that people do present differently in terms of their symptoms, it also focused us on pathology and how that relates to pathology, which we know is a bit of a slippery slope, because we don't have any real strength of relationship between those two variables, and that is pathology and pain. But I think, overall, there were some principles that clinicians can take out of the continuum that were, hugely positive and helpful, as well as now some of the things that we look back on and think, I don't think it's positive to be thinking about pathology and how pathology can influence our management, and that's sort of, in a way, one of the things that the initial continual model was putting forward. So that's sort of, I guess, the current day interpretation of where we can go with the continuum at the moment. But absolutely, it was ahead of its time and also helpful at the time and very popular as well.
Fantastic. I guess what we're talking about, I mean, for me, everyone's going to have their different moments, but another thing which struck me, and I can't remember when people first started talking about it, but it appears in quite a few papers, and that's the change in nomenclature, in the fact that when suddenly people were talking about tendinitis, and then suddenly I remember, I think it was around, for me, it was maybe 2010 or 12 or something like that. And it was like, oh no, mustn't be talking about tendinitis anymore. And that was kind of in reference to, hold on, it's not all inflammation, which is a big thing, because there's probably still listeners out there today who, not by no fault of their own, it's just what they've been taught, it's where their education has taken them so far, who are still treating all tendinopathies as an inflammation, and they're giving their clients NSAIDs and stuff, and they're getting frustrated and getting a bad reputation because their clients aren't getting better. So do you recall when the kind of changes in names came about, and were you involved in that? And
yeah, it was, it's sort of, if you look at what is it? Is it Google Ngrams, where you can look at the names over time? I think it is.
I mean, I've got the only thing I found online was, I think it was Karim Khan and Jill Cook in 2002. They had a time to abandon the tendinitis myth. Now, I don't know whether that was after a period of thought or other papers, but that wouldn't be the one I heard, because I was not as clued up back then in 2000. But yeah, they said time to abandon the tendinitis myth, which was all but I think they referred to Mafuli as well.
Looking at Google Ngrams now, and that shows you in the online world what the usage of those words are. If you look at tendinitis, it sort of peaked around probably just before 2000, and now tendinopathy's just overtaken it in the last few years in terms of representation online. But it's still, they're still used interchangeably. Basically, I think officially, to answer your question, officially, Nicola Mafuli put out a paper. That was the first one that talked about tendinopathy. That was probably early 2000s, I reckon. And then slowly, it started to then become more used. But we recently had a consensus among international experts where we officially put forward that we should be using this tendinopathy term, not tendinitis. And it's not wrong. And as you say, it's sort of, we thought initially in the 80s that it was all about inflammation, and that then leads people to go down the path of resting and taking anti-inflammatories, which doesn't really help in the long term for most people. So that partly that reason, but also the fact that the pathology is much more complex than just inflammation, and it's probably a little bit of a simplification to say it's just tendinitis. And so tendinopathy is a broader term, and it can encompass inflammatory changes and other things as well. So that's sort of, where it's gone. But it's good to see Google Ngrams, it's starting to become more popular. But if a patient calls it tendinitis, I just go with it. I'd say to them, look, we actually, it's called tendinopathy, and this is why. But tendinitis is fine. If they want to call it tendinitis, that's absolutely fine. It's probably a bit patient-centered as well.
Unless they're going home and necking ibuprofen or something,
Yeah, exactly. Yeah. So it's all about their beliefs and what that term causes them to do, rather than the term they use.
Okay, fantastic, great. So relaxed back. You just perpetuating the kind of generalization about Aussies at the moment. It's just couldn't be more laid back. If the patient wants to call it tendinitis, they can call it tendinitis. It's fine. So chilled out. Right, let's bring up stereotyping. I'm here. Right, let's go to the next few years down the line and have some of this in here. Let's hide that. What do we got here? Let's bring it on full screen. Right, so this was imaging, which you've done a lot of papers on as well over the years. This was 2005. Okay, so we're still in the same kind of time. You haven't got to remember this exact paper, but I'm interested in general about where we are, or where we were, and where we are now with regards to imaging, because we hear a lot about you should only use imaging to confirm your hypothesis. You should never use it to try and get a hypothesis, and that's maybe a generalization. What's your history with imaging and tendinopathies?
Yeah, it's interesting. So basically, I do use imaging in the clinic. In my clinic, I mainly see Achilles tendon, also some patella, and some sort of a spattering of other tendons. But I do use imaging, and I find it useful. It's absolutely, I guess the first thing to say, it's absolutely not necessary for diagnosis. So if you're trying to diagnose a tendon problem, imaging is not necessary. The diagnosis is clinical because it's a clinical pain condition that we're treating. So you don't need imaging for the diagnosis. It can be helpful for, I think personally, the biggest reason I use it is for patient engagement. So what I mean by that is, if the patient sees that you've taken the time to do the imaging yourself, they feel, rightly or wrongly, that you've understood their problem at its core, which is the tissue level. So that sort of, I think, is quite powerful, that I've found in my practice. And it's really from, I guess, an interest in using it in research that it's sort of crept into the clinical work. And I've been imaging people there probably for the last, say, 15 years. But as I say, mainly the Achilles and patella. But there are also other reasons to look at imaging, and that could be if the diagnosis is unclear, or if people are not responding in the time course that you're thinking they should be responding. If you suspect a red flag, if you're considering an injection or invasive procedure. So there are other reasons to image. But for me personally, they probably don't, they're probably quite rare. So looking at Achilles, I might image 20 or 30 people with an Achilles problem. And within that 20 or 30 people, you may not find many with a differential condition or other things going on that sort of warrants the imaging. But you do commonly see benefit in people who are reassured by your explanation of the imaging and how you contextualize the imaging. So I think that is, for me, a very powerful thing and a powerful tool that we can use. Having said that, I know there'll be a lot of clinicians listening thinking, I don't use ultrasound in my clinic and I haven't got access to ultrasound. You absolutely don't need it. You just need to be able to explain and understand the image and explain it to the patient. That's really, really important, I think, because patients do worry about what is on their scan. They worry about the imaging. They worry about what's going on inside their body. And we know that from a lot of the qualitative work that we've done, asking patients what their experiences with their tendon problem. So that, I think, having that ability to contextualize the image is very, very, very important. Yeah.
That's interesting. I love, again, it just shows an evolution of thought of the patient would really benefit from this, the visual, to help that therapeutic alliance, and they want an explanation. Just playing devil's advocate, but is it still the case that, like, for example, symptomatic people suffering from tendon pain may have an imaging that doesn't show anything, and vice versa? Is that not a problem? So
Yes, yeah. And that's the reason why we shouldn't use it or hang our hat on it for diagnosis.
Okay.
So we know that there's a whole stack of people out there who will be having imaging changes but not have any pain. That's really common. Now, in that paper that you flashed up, we also showed the opposite, which is people who have tendon pain but don't have imaging changes. So the two ends of the spectrum are possible. Now, the one that we've shown in that paper is not as common. It's far more common to have some pathology changes when you've got imaging. Sorry, some pathology changes when you've got pain. It's far less common. Sorry, I'm getting completely confused now. Must be 6 o'clock in the morning. It's far more common to have pathology and no pain. That's really common. The other one is less common. That's why we published that paper, because we were surprised in our cohort. And again, that goes back to the large cohort I was talking about earlier. We found these people who had clear patella tendinopathy, but their imaging was completely normal. So, if you are seeing that, it's possible that you've still trust your clinical diagnosis. That's the take-home message, because that's the most important thing.
That's good to hear. That's good to hear. With regards to that, what are some of the, I suppose to a certain extent we can generalize if we're working with tendons, what are some of the kind of things which flash up in maybe the subjective, which take us down the road thinking this is probably a tendon problem compared to a muscular issue or a bone issue? What are some of the kind of giveaways?
It does come down to things like the pain being localized to the tendon. It comes down to load-related pain, so some pain with activity generally, sometimes after. It comes down to there will be things like tenderness on the tendon. It comes down to what else? They're probably the main ones. We recently did a consensus that we're writing up now for publication. We sort of had a consensus of 51 international experts trying to understand what the best ways to diagnose Achilles tendinopathy are. And I say that to people, and they sort of think it's obvious, it's actually easy to diagnose Achilles tendinopathy. But it was interesting how many really interesting thoughts and diverse thoughts came up in this 51 international experts around the world who see lots of Achilles. Even there was quite diverse views about what we should be doing. But they're the sort of things that came out top of the list. Basically, it's simple stuff like this: where the pain is it load related, and does it flare up with things you think it will flare up with, like walking and running. That's for Achilles, obviously. So yeah, it comes down to quite simple sort of clinical questions more than the actual tests and the imaging that we do.
That's another great message to hear as well. So yeah, form your hypothesis with the subjective and then test it using the objective rather than going straight to the objective. That's a nice message.
Exactly. So by the time you finish the questions, you're pretty much already there. And then as you say, you're sort of just confirming it at that point. Yeah.
And we've heard from a few guests now that if you've, I'm terrible, Amy, but it's been mentioned a couple of times, but if you ever find yourself banging your head against the wall thinking, what is going on here? I've missed something here and it's driving you mad. Then the advice was just start a conversation again with your client and let them go over it again. And because you've probably missed something, or maybe you haven't put them in a state of mind where they've revealed it. They might not have told you something which is important. The answer is still going to be with them rather than doing more tests and doubting yourself. I can't remember who said that, which I give them credit, but
absolutely. That's great advice. Yeah. Listen to your patient, basically.
I'll remember shortly. Anyway, what about, I'm just interested how supported it is by the research, but I know in my own practice, when it comes to tendinopathies, we're looking out, because this applies to assessing and also when it comes to loading, the whole kind of 24 hours, like, for example, if they say, well, they might even realize but that the pain is coming 24 hours after the activity. But is that something if you get them to look out for it, is that something which might be a giveaway as well? This kind of delay, this kind of window where the tendons don't seem to react?
Yeah, look, it is quite variable, and that's where a lot of the discussion was in this Achilles consensus group around diagnosis, because it's, most people have morning stiffness, but some people don't. Most people have that delayed pain that you're talking about, but some people don't. So it is quite variable. It's not that none of these things are completely universal, and that's where the nuances of diagnosis come in, because you sort of look at the whole package together. You don't look for the one single feature. So I think that's right for most people, but it can be missing for some people as well. And we sort of need to consider that.
So you got to, not go by one characteristic, but kind of combine them all and see if there's a. How about the whole? What was the other thing I wanted to mention to you? Yeah, the kind of warm up effect where, I mean, again, it might be confirmation bias, but we do find that with runners with Achilles tendinopathy or maybe a hamstring, that one of the problems is when they start warming up, they think, oh, it's gone, I'm feeling good now. And then they overstep the mark and they go that too much of a distance. And especially, and it might start hurting later on because they had that positive experience in the beginning. They're kind of like not sticking to the protocol. So is that something which will vary, or is that maybe another characteristic of tendons?
That will also vary, along with everything else. So some people do get that very, very clearly, other people don't. And also it may be that they get that, but maybe it's not their Achilles, it's something else. So this is where the nuances of diagnosis are. Most people think diagnosis is quite simple, but there is a bit to it. And I'm looking forward to writing this up, because it was going back to learning, which we were talking about earlier. For me, as an experienced Achilles clinician, thinking, diagnosis is quite straightforward, but doing this study it was a really good learning experience as well, because you got a lot of different perspectives from very experienced people, which also changed the way that I think partly as well. So looking forward to presenting that, and I think it will be some clinically useful bits in there for clinicians as well. So we're just preparing it now.
That's amazing. And did you say that was like 51 of you getting together and just talking? That's gonna be incredible. Amazing.
51 from all over the world. So it was good. It was a 4-part Delphi study. So just interview, like questionnaires online over 4 parts where you reach consensus. Not easy to get consensus among a bunch of experts, because you get very strong opinions,
of course,
lots of comments. You get essays of comments basically that we have to sort through. But it was good. It was a good process.
That's cool. Okay, how about, I'm just conscious of the time, what about when it comes to I don't like the word treatment. I can't remember again who it was, but we need to move away, particularly people from sports therapy and from a manual therapy background. I think they need to move away from the word treatment, because it sounds like we're just going to do stuff to it. But so with the management, with the loading protocol you talk about, I'm interested in moving on. In fact, I think the next slide kind of mentions the buzzword that I wanted to bring up. Let's put it on a whole there. Eccentric. So I'm interested about how far the evidence supports current themes in loading, like the difference of starting off with isometric and then going to eccentric and then slowly bringing in some concentric. Is that something which is still quite supported, or not?
I think there's not really any evidence from what people put forward, and myself included, in some of the topical reviews and some of the narrative reviews that are sort of clinically focused for people. With a lot of people have put forward the view that you start with eccentrics, you go to isotonic, you go to stretch, shorten, cycle, or hopping, jumping, and other things that involve speed and power. There's only one study that I'm aware of in the whole literature that supports that. And that is the study by Brader, published a couple of years ago in Patella tendon, where they compared that approach to the approach of just doing eccentric training. And they did find that it was superior. They did find it was better. So, I mean, that's at least some evidence for a progressive approach Personally, the way that I think about it is you're trying to recover someone's ability to do something that they enjoy doing. So it's more about what's that thing that they enjoy doing? How can I break that up into small parts and get to it eventually? And that sort of, and if that does involve going from isometrics to isotonic and then going to whatever activities they enjoy, fine. But some people can get there in a more sort of direct way and just start the activities they enjoy. So I guess what I'm saying is you don't need to do isometrics. You don't need to do isotonic for some people. You just need to recover their function. So I think moving towards more, how can we get someone to be able to achieve this goal is, I think, probably where it is starting to move to, rather than I have to go through this rehab pathway that involves all these different elements. And I'm not saying not to engage at all in rehab. Rehab is, I think, important for a lot of people as an avenue for getting them towards being able to do the things that they want to do. But we don't have to be so wedded to an approach where we go through all these phases and has to be isometric first, has to be this second. I think just looking at what they would benefit from, and that's where the skill comes in. So would they benefit from maybe having a stronger muscle? Would they benefit from doing things, in this functional pattern versus that functional pattern? Would they benefit from doing things that involve a little bit of power and speed for their tendon, or a bit of hopping, and just trying to understand, where that person is at and what type of benefit they'll get. So that probably is a long-winded answer to your question.
No, it's great. No, I think it reminds me of actually. I was looking at, I don't know whether this was in one of the abstracts, one of your papers, or whether it was something that I just came across when I was looking, but it was the idea of principles instead of recipes. Was that something you put into? But I mean, that's what's reminding.
I think it was me, but yeah, it sounds like something I've come across. I can't remember where though. Yeah.
I think that's quite a nice advice, isn't it? We are teaching you principles. So in theory, make sure they can do some isometric and see if they're happy with it, because they might be surprised that they can't do it and then move on. But it's not like a recipe. You have to do 2 weeks of this and then. So I think and that should be also kind of common sense, really. Just how is the patient getting on with it, rather than, according to this, I need to do this now, but I'm fine. Yeah. Shh, don't interrupt me. It kind of is common sense,
Yeah, what about exactly right? Because it's sort of getting back to the orthopedic days, isn't it? Where we had like a protocol, and we say, 2 weeks you do this, and 3 weeks you do this. And that it just doesn't work like that in the real world.
But I guess that's another. Yeah, I can go straight to that now. I just I'll put in a pin in one idea and just come out with that one. I think that's another thing which is important with tendinopathy as well, is it's difficult for that reason to give like a time frame. It's important to let the patient know, because it could go on for a long time. But then you should be prepared that some patients might kind of accelerate quickly through the rehab and just do something incredible. But that makes it tricky with patients, isn't it? When they say, how am I suppose, again, it takes us back to, you've got to be honest. Just say, well, it depends how you react. I can't give you an answer, I guess.
You do. Yeah. It just depends on the individual. I was in clinic on Monday, so 2 days ago, and a guy walked in who was literally walking on their toes. He was walking on his toes, so he limped in to the consult room, walking on his toes, and I thought, here we go, this is going to be a real severe Achilles tendon, because he can't even walk on it. Turned out his brother had 2 ruptures of his Achilles tendon, and he was petrified of rupturing his Achilles tendon. So he was just protecting it, and he was walking that way, and he'd been doing it for 3 months since he first felt a twinge. And this guy had almost no pain whatsoever, but he was walking on his toes for 3 months, trying to protect it from rupturing. So it really does, and he was pretty much fixed in one session. when I reassured him.
Yeah, mate.
Literally at the point where he was hugging me when I said to him, it's not going to rupture, don't worry.
Wow.
It's incredible how diverse people present and how their beliefs and other things and how, as you say, the time course can be quick for some, if you're sort of able to take them down that, a path. So it really is. Yeah, some people need lots of input and rehab, and you're right. Some people will need that reassurance of, yes, it's going to take a long time.
And this person you're talking about, without giving too much away, were they an athletic person or were they non-athletic? Or
he's not an athletic person. He works in a salon. He's on his feet all day. He's limping around on his feet all day, and he was telling me his patients are sort of giving him weird looks. Not his patients, his clients are giving him weird looks because he's limping around. But he does a bit of gym stuff. He's got a trainer and he does some gym stuff. He's also probably giving a bit too much away now. Musician, where he does use his foot as well. So
okay, so that falls out the banjo.
Yeah. There's a few things there, but just a very interesting presentation.
Yeah,
which is
amazing.
Yeah.
Amazing. I wanted to. What was the thing I put a pin in? Oh yeah. So heavy slow resistance, something which we see a lot of people proposing it, and it seems to be that that's what tendons respond best to, and reduce the volume. And is that again something which is supported by the evidence, or is just a logical way to do it, or what?
Well, I think when you're talking about this type of exercise rehab, you've got to also be clear about what the outcomes are. Mm-hmm. So if you're looking at the outcome of what the tendon responds to, if we interpret that as tendon getting stronger, then heavy slow resistance is probably a good way to go, because the tendon will adapt with that type of loading. But if you're talking about the outcome of pain, just getting people less painful, more functional, able to do more things, it probably doesn't matter what type of loading approach you take. And that's really clear in the evidence. You can get people's pain better by doing the old-fashioned eccentric, by doing heavy slow, by doing other things. So pain outcome is different to, say, tendon adaptation outcome, and there's no clear evidence that we need to adapt the tendon or get the muscle stronger. Maybe you can make the argument that if someone's got a really weak muscle, really weak tendon, then it's a beneficial thing to do heavy slow resistance. So I can see that argument that people make, but it's also important to know that you can maybe go back to that approach we were talking about earlier and just gradually reload someone in a functional way, and that might be enough for some people without doing the heavy slow. So that's almost like a CFT approach, like they do in back pain, where they're just, you're just gradually starting to load someone. And this guy that I was talking about that I saw Monday, that's pretty much what I did with him.
Yeah.
So I didn't bother doing, because this guy's been walking on his toe for 3 months. He's probably got quite a strong calf muscle because he's been loading it on his toe. So someone like that, I just start with just start to load it again. Just start to load through dorsiflexion. Get used to doing that again. Just see what happens. Gradually give him some goals about loading over a step, and that might be enough. So, as opposed to, say, going through, right, we need to strengthen your tendon, we need to strengthen your muscle, we're going to do a heavy slow resistance type program with you. So it's useful, but I think it comes back to what's the goals, and is that goal important for that person?
Yeah, brilliant answer. Great. Yeah, it depends. Again, I was thinking with the runner's head on, where we're looking at each step is going to have to deal with quite considerable loads and multiples of body weight. So, but yeah, if they're not going back to run, then they're not going to need either that heavy load per step or that cumulative load if they're running miles and miles. What about if we are with regards to kind of like synthesis of collagen and kind of, again, looking a bit through the biomechanical lens, but if we know there's been degeneration, if it's a chronic thing, we need to stimulate that repair. Is that where the idea of the tendons do respond to heavier, slow, as opposed to, that's where it does come in?
Exactly, yeah. So the weight of evidence at the moment does suggest that tendons respond to heavier. So if you do want to get the tendon stronger, it does have to most likely be the heavier type stimulus that you're doing. There was actually a really interesting paper that I did do did I do one? Yeah, I think I did a Twitter post on it last week or the week before, where they found that even moderate intensity loading did lead to adaptation in the tendon. It was by the group in Copenhagen. They found that 55% of 1RM, because the heavy slow resistance is all 70% 1RM or above. This time they did 55%, and they still found adaptation in the tendon, which was interesting. Yeah, and I think that's one of the first studies to show that. So it seems like maybe that is also being challenged a bit, that thinking that we do need to go super heavy with the tendon. Now that's only one study, so we do need more evidence.
What population were they, sir? Who were they?
They did young. They had a young group and they had an older group of fit and healthy people.
Not for a particular sport. It was just
not from a particular sport, from memory. Just fit and healthy people, and there was a group that was older, say over 55 or something, and a group that was younger. Yeah, so it was interesting just to read that. So there might be options with how we look at it as well. Yeah.
So it's still kind of, in summary then, in a way, it's still not black and white at all. In conclusion, you've still got to base, I suppose really it's the principles and not the recipes, which seems to be the message that sums it all up. We have got some ideas, but always apply it to the patient in front of you. And also kind of like some of them are simple, like it's not always going to be an inflammation problem. I think that's probably even today, I don't mean that disrespectfully to people thinking, well, I thought tendinopathy, we always give them inflammation and give them to rest, but that's something where some therapists still need to update a little bit and move on. Fantastic. There were so many other papers and stuff I wanted to go through with you, but it's just too interesting.
We've got to do 2 hours next time.
Yeah. Oh, okay. Well, you said that now. I've got it recorded as well. So the best thing I can do, the best use I can make of this time now is probably to let people know about, if they are interested in the education and they enjoy the way you've put it across, then you've got online versions of your famous course, haven't you, which people can tap into as and when they want. I'm just going to put this on the screen for people who are watching the YouTube recording or have joined us in the live lounge. So tendinopathy rehab, the website you need to go to. Let me just check. It's .site, isn't it? It's not a com or something.
Site,
yeah, exactly.
Site, yeah. Yeah,
let's check that. And if they go there, then they can find details for the online course. Is it for anybody, the online course? I've got another shot here.
We pretty much have all types of people doing it. So we, from doctors to physios, myotherapists, sports therapists, pretty much everyone. Yeah,
fantastic.
We get we get a range of people who do it. Yeah, so it's basically it's online modules covering hamstring, gluteal, patella, and all the foot and ankle tendons.
Marvelous. And I guess because people are working at their own speed and kind of level, then they can look things up and take as long as they want to get through, as opposed to trying to keep up with the course or something. So they've got that advantage.
Yeah, exactly. Yeah. And there's modules. You pass the module, you have a quiz, and then you go to the next one. So it's like a gradual thing. You can take your time. and do it as slowly as you want. Yeah.
That's cool. So yeah, people head along to Tendinopathy Rehab. Remember, tendon is an IN as well. Like it's just stupid English, but it's just like tendon. I know is an ON, but as soon as you stick anything on the end of it, it becomes a tendin. I don't know, it's ridiculous, but that's the way it is. Just in case you're struggling to find it, not everyone knows it. So tendinopathy-rehab.site, and you'll find details of that. And yeah, I mean, we never say there's one CPD that everyone should be doing, but if you are into tendinopathies, then the guests we've got on the show is definitely, you're not going to go far wrong if you tap into some of that information. And then also, if people want to keep in contact with you, and you do put a load of great information out there, you've got Instagram, which is Tendinopathy Rehab. You got Facebook, which is Tendinopathy Rehab. And then Twitter, God bless you, still on Twitter, still putting things on there. That's Dr. Pete Malliaras, which shows how old that account probably is. But yes, he still managed to get stuff out.
That was the first social media account I got, actually, Twitter one. Yeah, that was people are sort of moving away from Twitter now, aren't they? But I still don't mind it. Twitter.
Oh no, it's great. It was my guest a couple of weeks ago was Joe Gibson. I'm not sure if you're familiar with, you probably hopefully are. Yeah, and I found her Twitter account because she was Shoulder Geek 1, which kind of was before it was cool to be a geek. Now I think there's about 120 geeks of all different things, but she was Shoulder Geek 1 back in 2012 or something. And I told her how many tweets she'd had. It was something. It was, I don't know, it's like 475,000 clicks of send, and she was like horrified over those years. But it's crazy how much was sent over.
Crazy. Yeah,
quite scary.
Yeah.
Right then, well, as Cecily Hislop says, I think that sums it up nicely. As someone who has sporadic Achilles tendinopathy, this has been so useful. Thank you, gents. It is kind of cool, isn't it, when you're a clinician? I remember when I first read Born to Run, bless it, the book, and I was in Mexico on holiday, and I was running along the beach with no shoes on, hearing the sound in the wind of the Indians telling me what to do. And double Achilles tendinopathy. When I got back to clinic, I'm limping around, probably like your mate who came into the clinic. And I remember my boss saying, Matt, you realize you don't have to experience all injuries to treat people, but it kind of helps, because I learned then, it's what it's like for people when you are injured. ProCare Sports Medicine. Oh, look, who's with us? Andrew McCauley's here. And he says, that's the second time you've joined us, man. This is becoming a regular thing. Did Peter's course years ago. Brilliant and so generous with his time. Top guy. Well, look, coming from Andrew, that's a great testimonial. That's very kind. Thank you, Peter, for joining us. I really appreciate it, especially at the really early time. We're going to be joined next week by a colleague of yours, also in your wonderful land, your massive land. So Alison Grimaldi, Dr. Alison Grimaldi is going to be with us, doing understanding tendinopathies of the hip and pelvis, which is obviously Alison's speciality. That's going to be next week at 9 o'clock. And then also from your neck, what is it about Australian tendons? Is that just because of the trope?
I don't know. It must be something in the water. It's weird.
Massive spiders and tendon geniuses. I don't know what's about.
It is because you've got Bill Vizencina, you've got Ebony, you've got Jill, it's just but I think Jill is probably to blame for a lot of it, because Ebony and I came out of her.
Right, okay. Jill's to blame.
Jill's to blame. Blame her.
Great. So Dr. Ebony Viobi she'll be with us at episode 200, which is May the 28th, managing tendon pain being one of her specialisms. So that's going to be really cool as well. So if you can join us live, if you listen to this and enjoy it, then listen to the recording, then join us live on any of those dates. If you can't and you enjoy the content, which is all obviously free, and it's just from the kindness of Professor Peter Malliaras' heart, then do kind of just leave a recording, leave a review, because it just helps us appear high in Google, and everything that Peter said tonight will appear high in Google, which is just helping our industry and everything, just what it's all about. So please do that if you can. Once again, Professor Peter Malliaras, thank you so much for your time, mate. And
no worries. Thanks a lot, Matt. Thank you.
We'll talk again soon. See you, everybody. Take care.
Good. Thanks, everyone.